Okay, good afternoon, everyone. Welcome to our webinar on appendix cancer. A few reminders here. Please remain muted when you're not speaking so that we cut down on background noise. This webinar it will not be streamed to Facebook Live, but it will later be uploaded to YouTube. And as always, please use the chat box to ask any questions that may come up for our speakers during the presentation. You can just ask in the chat box, or if you want to ask a question anonymously, you can find my name, Aaliyah Poulos, and it should be on there. It should say host or co-host next to it. You can find my name and ask your question directly to me, and I will ask it aloud on your behalf. So this webinar series is part of the programming from the University of Chicago Medicine Comprehensive Cancer Center, Office of Community Engagement and Cancer Health Equity. So as I mentioned, my name is Aaliyah Poulos, and I'm an education outreach specialist in this office. And you can find my name during the presentation to ask any questions anonymously or to just ask any questions about our office and the work that we do. We have three speakers today, so we're really excited. We have Dr. Mecker-Muller, who's a professor of surgery, director of regional therapies, and the director of the Surgical Oncology Fellowship Program at the University of Chicago Medicine. We have Dr. William Wong, who's a surgical oncology fellow, and Colette Brotman-Ebsen, who is a physician's assistant in surgical oncology, all at the University of Chicago. So welcome, welcome. Thank you all so much for being here. And I'm going to stop sharing my screen and throw it. I believe, Dr. Wong, you are going to be leading us off here, right?
Yes.
Okay,
Just making sure you can hear me.
sound great.
Okay. And you can see my screen.
Looks good.
Perfect. All right. Thank you very much for the introduction. And thank you very much for having me. I know everyone's from all over Illinois, but yes, my name is William Wong, and I'm the Surgical Oncology Fellow here at U Chicago. So I'm going to introduce a little bit about some of the basics of appendix cancer. We'll start off by highlighting the annual case number per year, as well as a little bit about the anatomy of the appendix. And then I'm going to introduce the concept that there are a lot of different types of appendiceal tumors or neoplasms, and because there's a lot and it can be confusing at times, I want to emphasize that that it is important when we take care of these patients that there's a multidisciplinary care. And of course, I'll talk about how appendiceal neoplasms or cancers present itself and some of the workups and treatment options that we may have. So appendix cancer is relatively rare cancer. There's about 3,000 new cases in the United States per year. And for comparison, breast cancer has about 310,000 new cases every year. Colon and rectal cancer has about 150,000. So comparatively, 3,000 is small. However, over the last 2 decades, if you look at that graph, starting from the turn of the century, there has been an increase in the rise of cases. Um, so that's one of the reasons why we're talking about this subject today. So where is the appendix? The appendix is in your right lower abdomen. It's essentially an outpouching or an organ that projects off the large intestines on the right side. For a long time, I remember learning this in high school too. The appendix was deemed to be a vestigial organ that's useless, and you can certainly live a healthy life without it. And certainly removing an appendix or an appendectomy is one of the most common operations that we do in the realm of general surgery. However, over the last few years, there's constant studies being done showing that there might be a function to the appendix. In fact, it might play a role in having an healthy gut tissue within the GI system. So this is going to be a busy slide, but I wanted to use this slide to emphasize again that there's many different types of neoplasms within an appendix. I'm going to define neoplasm essentially as abnormal cell growth secondary to the poor misregulation of cells as they grow. And so when we think about, for the purpose of this topic, I'm going to focus more on epithelial tumors. So epithelial essentially means cells being grown from the inner lining of a GI system, so the inner lining of the appendix. And when we think about tumors and neoplasms, they can be benign. So benign meaning they're slow growing. They tend not to invade or metastasize to within the abdomen or to different parts of the body. And then they can be malignant. And those are the ones where they can spread and be aggressive. So we can divide tumors, these tumors within the appendix as polyps, and then mucinous and non-mucinous. And I'm going to have some slides showing what I mean by that. Okay. And then we can divide that up into other different types of neoplasm. So again, I'm not going to go over every single details of each category, but one thing that I want to one takeaway from this slide is that there again are many different types of appendiceal neoplasms, and therefore it's important for one who's diagnosed with appendiceal tumor to be seen by a specialist, a surgical oncologist, because prognosis can vary and the types of treatment options and the aggressiveness of the tumor itself can vary. So what does it mean to have a mucinous appendiceal tumor? So I'm going to show some pictures, and so be warned. Um, this is a dilated appendix. It's not a normal appendix on the top left-hand corner. And the authors here opened up the appendix, and it shows essentially a jelly-like, snot-like substance. And so that's mucin. Um, in picture C, that's a view of a colonoscopy. So a GI gastroenterologist has a really long camera going all the way through the colon down to the right side inside the large intestines, and you can see that opening that enters into the appendix. You can see a snot-like um, viscous fluid coming out. So this is probably one of the worst case scenarios that you can see. Mucin can certainly spread, especially when the appendix perforates and there's mucin in there. It can spread throughout the abdomen. And here you can see we would call this PMP, which is short for pseudomyxoma peritoneae, where it's essentially a large blob of mucin encasing the abdomen. So when we have a non-mucinous tumor, they're essentially plaques that you can see along the linings of the visceral organs, the abdominal organs, as well as on the inner surface of the abdominal wall. So on the left-hand side, I'm showing what we call a diagnostic laparoscopy, which is important when it comes to some of the workups of cancers within the abdomen or just diseases within the abdomen. So essentially, we insufflate the air, we insufflate the abdomen with gas, and essentially, it's a long camera that we insert into the patient's abdomen to look for pathology. And all these arrows that are pointing to in the right-hand side, we're looking at the inside of the abdomen, and we see these plaques along the inner linings of the abdominal wall and the mesentery or the tissue that supplies the blood vessels for these intestines that you see over there. So I explained some of the types of appendiceal tumors. I want to go over some of the presentations that patients may have when they are not yet diagnosed with an appendix neoplasm. So appendix neoplasms can present incidentally. So what that means is, for example, you might have had a car accident and you had to get some imaging of your entire body. And we see this abnormal looking appendix and eventually, maybe you'll get an appendectomy or certain workups that might eventually lead to a diagnosis of appendiceal cancer or tumor. Or they could present like an appendicitis. And when I say appendicitis, I mean an inflammation of the appendix secondary to a possible infection. And so they can present very similarly. So what are some of the symptoms? They can include pain on the right side where the appendix is, a fever, loss of appetite. Your belly might get swollen. You might have some diarrhea or constipation, some nausea or vomiting. And one thing that might differentiate an appendicitis from symptoms of appendiceal cancer is potentially you might have noticed some weight loss over the past few months. So what are some of the initial workups after a diagnosis of appendix? So when we think about treating and diagnosing cancers, there's this mnemonic that I always think about. We diagnose it, which might involve taking a specimen or a biopsy of a tissue, or the appendix sometimes, as I mentioned, might have been removed already because it was presumed to be appendicitis, and so we diagnose it from getting a tissue sample, and then we have to stage it. And what that means is we have to get imaging to confirm or just to rule out that there might have been spread already of the cancer throughout your body. And then we do blood work. And so some of the blood works might involve tumor markers to determine whether there might still be disease inside your body. And we do genetic testing, and genetic testing helps us determine um, possible treatment options or treatments that might not be helpful, as some cancers can have certain mutations that are resistant to certain therapies. And then, of course, a colonoscopy. A colonoscopy, again, as I mentioned, is essentially just imagine a long camera that goes from your bottom, your anus, and goes all the way to look at the rest of your colon to make sure that there's no other cancers within your colon. And so, management of appendix cancer it can be very complicated, and we have shown through evidence that patients do best when they're taken care of by a team of doctors, a team of advanced practitioners, and other health staff within the medical community. So we're the surgical oncologists. However, we rely on the radiologists to help us identify images or identify certain locations of potential tumors or recurrences within images. We have medical oncologists who help us and guide us through the treatment options that our patients can get. And then we have other specialists, such as palliative care doctors, to kind of discuss with our patients and their families about goals of care, social workers, and well as pharmacists. So, uh, again, within the management of appendix cancer, there's a lot of treatment options, and it's not just surgery alone. We have systemic therapy, which can be divided up into other different types. So, chemotherapy. Immunotherapy is a hot topic over the last decade, and it involves enhancing your immune system so that it can fight cancer cells. And then target therapy is when there might be a certain protein or certain mutation that's specific medications can target and attack those cancer cells specifically. And there are times where surgery might not be ideal, whether it's because the metastasis might have spread, and so we rely on our colleagues and this multidisciplinary team to determine that other therapies might be more appropriate, and maybe surgery might be possible down the line. So, what are some potential options for treatment? For surgical options, depending again on the type of cancer, there might just be removing an appendix itself, and that's it. Other times, depending on the aggressiveness of the tumor itself, we might have to remove the right side of the colon. But if the appendix bursts and, for example, mucin or non-mucinous implants of the tumor has spread, there are still surgical options. So, again, if the cancer has spread but remain in the abdomen, there are certain treatments that we can do, and Dr. Moeller is going to talk more about it. But we call this cytoreductive surgery, and essentially another term for it is debulking. So we all the macroscopic, the tumors that we can see with our naked eyes, we'll be able to remove surgically. Sometimes that involves removing certain organs within the body so that we can clear as much of the tumor and the much of the deposits as we can. However, there might be some tumors that we can't see, and the way we treat those tumors that we can't necessarily see or so are too small, we can do what we call HIPEC. So hyperthermic intraperitoneal chemotherapy. And so on the left-hand side and the bottom, essentially, we can introduce heated chemotherapy liquid into the body, and that liquid, that chemotherapy can help us attack the cancer cells. And this is just a real life picture of two tubes that are going inside the patient's belly. We close them up, and so one tube infuses the liquid into the patient's abdomen, and then there's another tube that evacuates the fluid. So say we treated the patient surgically as well as a combination of systemic therapy. How do we survey the patients and what are some of the options for surveillance? It's very similar to the initial workup that I showed. So if there's concern on imaging, for recurrence, we might get a biopsy. We'll continue to do colonoscopies, and then there are certain blood work, blood biomarkers and tumor markers that we can continue to follow to determine whether there's any concern for recurrence. So, in summary, appendiceal neoplasms, appendiceal cancer can be very rare. They are usually found incidentally or after symptoms that are similar to appendicitis. They can be very complicated, and that's why it's important for patients to go to a tertiary or quaternary center to be taken care of not just by a surgical oncologist, but by a team of doctors and advanced practitioners to optimize prognosis as well as quality of life. And regardless of the stage and the aggressiveness of the type of appendiceal neoplasm that you might have, it is treatable. But prognosis is certainly best if cancer is caught early and it's localized. So thank you very much for your time. Happy to take any questions, whether it's now or later on.
Thank you, Dr. Wan. And I'm going to jump to the next step of our presentation. Hi, I'm Dr. Moeller. Thank you for having us here. So I'm just going to talk about what happened when the disease has advanced and what kind of treatment strategies and outcomes we use. So we're going to talk about what the pseudomyxoma peritonei is, what to expect after the debulking and HIPEC, the different type of outcomes and survival outcomes that we have depend on which type of tumor you have, what happened when you had disease that we can no longer remove, and what palliative options are there for helping the patient have a quality of life. So pseudomyxoma peritonei is basically the jelly belly that Dr. Owen was mentioning. Is tumors that produce this mucin. It looks like jelly and is mixed with the get all over the organs and can be very debilitating because it start filling out the abdomen. There is about only 55,000 cases a year, and by 2025, these numbers appears to be increasing. Now, not only the appendix tumors can produce the pseudomyxoma, it can come from tumors from the ovary, from the colon, from the remnants of what was the urinary tract, the gallbladder, for example. But for purpose of this talk, we're gonna focus on those ones that come from the appendix. And you may hear the term lamin, which means the low-grade mucinous tumors that they don't have the cancer cells under the microscope. It's mostly all this jelly material that we found on the belly that sits around the organs and tend to strangulate certain organs because of the mucin start drying up and start kind of crunching the intestine and other organs in the abdomen. Then they had the high grade, which are tumors that the cells look a little more like cancer. And then we have the goblet cells and the Signet cells. And we're going to explain a little bit of those. In this scan, what you can see, the white part, those are the intestines that are kind of pushed to the side, and the rest of the abdomen is this gelatinous material. So it's very difficult sometimes to drain that because the standard a malignant ascites that we're used to see with other cancers that is more liquid, in this case is like jelly, so it doesn't come through the catheter. And start, like I say, kind of entrapping the organs within this gelatinous material. The abdominal cavity will distend, but to a point. There will be a moment when there is no longer space for the organs and all this mucin that is entrapping the organs. This is our very advanced pictures of the disease. This is something that we will call non-resectable. That surgery won't be able to clear this amount of disease. And now these are a little bit intense pictures, but it's just to give you an idea how these things that you see here, this is the mucin with the omentum, and it's like all this gelatinous kind of like cranberry sauce type of thing. And this is a loop of intestine, and it's just crunching trap into this mucin. This is another patient, real life patient. This is how sometimes the abdomen can look like. And when we debulk that, mucin is not just debulking the mucin. We have to resect the organs that are entrapped by that mucin. And it does help the patients with their quality of life because it's like being with a triplets, with very large babies walking all day. So their body takes a toll. And when we debulk that, the patient has more normal anatomy to be able to mobilize around. So, and like as Dr. Wong was saying, we have what is the cytoreductin HIPEC. This was actually called the mother of all surgeries. This was coined by a patient in a blog. Some people call it the shake and bake, the sugar baker surgery, or just the HIPEC. But it's required removing multiple organs. And these surgeries are going to have either a curative intent, which is when we can remove all the tumor and give the chemotherapy. But in some cases, we cannot remove all the tumors and we just remove as much as possible. And with the HIPEC, and then that's kind of give us a little bit of palliation, but it doesn't cure the disease. It's just help the patients to have a little more quality of life. And that is not for all the appendiceal cancers, only for the low-grade tumors that we can debulk. Even if it's not 100%, we can still help the patients. More aggressive tumors, doing just the partial debulking, the tumor come back too soon, that the benefit is very limited. And then there is what is called fully palliative, when we use aerosol chemotherapy to decrease to slow down mostly the progression of the disease, or when there is ascites, because as Dr. Wong explained, there are some tumors that have only the cancer cells, and those ones had the clear ascites, and then we had the mucinous ones who have the jelly belly ascites. So what would you expect after surgery in HIPEC? Well, it's going to be depending on how extensive your surgery is going to be, how much tumor is removed, how many organs we have to remove, and what we need to reconstruct. Sometimes these tumors may be going through your abdominal wall, and we need to get and create a new abdominal wall in order to contain the organs inside the abdomen, and that is a surgery that has higher complications and that needs longer recovery. Sometimes we have to remove multiple pieces of a small bowel with multiple connections to have bags like the colostomy or the ileostomy. So all those things are going to add up to the recovery time. There are other cytoreductions that are more limited, that sometimes it's just to remove what the appendix was and the omentum, which is like an apron that covers the organs. And also, it's going to depend on how healthy the patient was before. See if the patient has good nutrition, if he has good physical condition, or if he has received previous chemotherapy that may have debilitated the condition of this patient. So we need a window for these patients to recover after chemotherapy, to get a little stronger, get better nutrition before we do the surgery. And usually that window is between 6 and 8 weeks to help us get the patient more stronger, and that sometimes require physical therapy as well. And also, the recovery is going to depend if the surgery is done traditionally way, which is the open way when we do the larger debulking, or minimal invasive, which is the laparoscopic or robotic surgery when we have more limited disease. So just to give you an example, the different type of implants, the one here in the corner, these are the solid implants. This is the how we see carcinomatosis when there are solid tumors. The one here at the bottom, in the lower corner, is a combination of both solid and mucinous tumors. And this other one that we have on the right-hand side is the mucin. But as you can see, that mucin is a trapper in the organ. So in order to remove the mucin, we have to remove the organ. And the extent of that resection to remove all the mucin of those organs sometimes require that we removed the part of the stomach, sometimes most of the stomach, the spleen which sits here, parts of the liver sometimes we have to remove, the gallbladder. Sometimes we have to treat the peritoneum, which is the lining that covers the organs, under the diaphragm, which is this yellow line. And sometimes the tumors are too thick that we need to take portions of that diaphragm and also reconstruct it. And the important thing is, a lot of the small bowels sometimes can get compromised, and it's important that there is only certain length that we can remove. The colon, sometimes we have to remove most of the colon as well. The bladder, part of the bladder or the gynecological organs. We have, like I mentioned, have to do sometimes the back. and the abdominal wall reconstruction. So all that is gonna affect how fast or how slow a patient is gonna recover to go back to the baseline. So this is another picture of a patient undergoing the HIPEC part. That means we have finished removing all the tumors. Sometimes there could be 12 hours of surgery removing tumors. And these are the tubing that is connected to the machine that you see in the back, and that is the machine that is recirculating the fluid, which is the chemotherapies in recirculating into the abdomen for about 90 minutes. This is a laparoscopic one. So in this one, you can see there is only 3 tiny pores. They are 8 millimeters each. And this is connected to the machine here. So this patient obviously is gonna recover way faster than the one that we have to do the larger surgery. So what are you expecting the hospital stay? Well, if we do the open surgery, you will be in the hospital for about a week to 2 weeks. If we do a laparoscopic and we have to remove colon, you can stay in the hospital for 3 to 5 days. And if we are just finishing the completion of the surgery, that sometimes they have removed the colon, but the omentum was left behind, we remove the omentum and we do the HIPEC. Usually those patients go home the next morning. What symptoms you are common to have after this type of surgery? Or if we remove a lot of the intestine and the colon, you may have a kind of diarrhea that may be for several weeks that we have to treat with hydration and to give you medication to harden the stool. You may have low appetite and you may need medications to help you with your appetite, get nutritional shakes, a lot of protein. You may feel very tired because your body's healing after a major surgery with low energy. You may have episodes of constipation, some episodes of nausea. The food may not taste as well. But most patients start getting back to the baseline at 3 months, and most of them by 6 months are what they are expected to recover to the baseline before they had the surgery. Now, a lot of people go back to work after 3 months. Some other people take longer time, but for the major, larger surgeries, that's about the average time, 3 months. So when we talk about the survival, which is a common the patients will have when they come, like how long I'm gonna live after this or how this is gonna help me to live. Well, the main indicators of giving us that answer to you, we're gonna have it after the surgery because it will depend on how successful we are in removing all the lesions. And you may see in your operative report something that say PCI score, which is an index of calculation in the abdomen where the tumors are located and what size those tumors are. So there's a code. So we calculate, we add these numbers, and we will come out with a number. Could be 10, could be 15, could be 39. So the higher that it start getting, the worse chances that we may not be able to remove all the tumors. And then is, okay, now we know how much tumor do we have, how much did we remove, and it's going to be how big the disease was left behind. So we try to don't leave anything behind, but sometimes it may be tiny little microscopic ones that a couple of millimeters that may be there, but we hope that HIPEC, the hot chemo, will take care of those little ones. And then there are tumors that we cannot remove because they are in areas that they are not compatible with life if we remove them. So this slide's a little bit, but what I want you to focus here is that in these two, you see on the side, I have the lamens, which are the low grade tumors. These are the ones that have the best prognosis because patients can live for a long time. They can have a survival with high number of these patients at 5 and 10 years. They can be alive, even if they have a recurrence, which about 1/3 of the patients are gonna recur. And the recurrence usually happen between 2 and 5 years. In the survival after we go back, we sometimes have to do 2 and 3 HIPEC, cytoreductions in HIPEC until it's not possible to keep doing it because it's not safe for the patient or not technically possible. And then we have the high grade, the signal ring cell, and the ones that are solid. And those ones are gonna need chemotherapy in addition to surgery in HIPEC. Because for the lamens, we don't use chemotherapy because it's mostly mucin, so there is no blood vessels going to deliver that chemotherapy. And chemotherapy has two roles, the systemic chemo. It's not just for the tumor in the abdomen, but for tumors that can travel to other parts of your body, like to the liver or to the lungs. So we need a combination of the surgery, the HIPEC, and the systemic chemo for these other ones. And the most aggressive are the signaling cells. Those ones are gonna, patients are gonna have higher recurrence rates, which mean they're gonna live shorter. And in between are the other ones. So all what I want you to remember is, yes, the best prognosis is the low grade, but we can still help patients with the pathologies that are a little more aggressive, but they have different, not all the patients are the same. Not the same, the neighbor has appendiceal cancer may have the same as the other neighbor. So they have different prognosis based on what is the pathology, what is the pathologist looking under the microscope. And then there will be patients that are not candidates for the high pick. These patients are patients that they cannot have surgery anymore, either because the cancer is outside the abdomen, is involving other organs, such as the intestine or the vascular supply. And the small intestine, there is only so much we can live without it. So when the entire small intestine or majority of that is involved, that is something we call not resectable. And when the disease is too large, too much, that the risk of complications are so high, or is going to decrease the quality of life of the patient. Or if the patient is progressing rapidly on chemotherapy, or we just did surgery and the patient come back right away with a recurrence, that means that this is not a good prognosis. Or those patients that cannot undergo surgery because they are too weak. So they're gonna have more ascites. They may start having episode of blockage, and sometimes these episodes do not resolve, and they get malnutrition, nausea, vomit, pain, weakness, the conditioning, and they have abdominal masses, fistulas, so very severe abdominal distension. So for those patients, most of the time surgery is not an option unless very limited, such as the compression ostomies, or most of the time we try to do things that are no invasive, such as putting a PEG tube, which is a venting tube in the stomach to help the patient with the symptoms of the nausea and the vomit. We treat them medically with medications, the pain control, and give them psychological support with palliative care. And the PPAC, which is the aerosol chemotherapy. This is just a picture of a PEG tube. It goes into the stomach. It's here. The patient can open that PEG tube to empty the content of the stomach. They can still drink liquids and empty it, but this is for quality of life. This is the PPAC. When we put the aerosol in here, you see there is a probe, and I put the aerosol in there. I'm just gonna play this quickly. So that's how it happens inside the abdomen, is putting the chemotherapy inside. And those are the options that we have. I rush a little bit because we still have to talk about surveillance, and I'm gonna let Colette take over now. And this is our regional teams. We have fantastic nurses and PA and dietitians that help us to take care of our patients, and I just wanna acknowledge them here.
Thank you, Dr. Moeller. And now Colette, I think if you could share your screen.
All right, can you see my screen?
Not yet.
Let's try again.
It's going. There you go.
Perfect. All right. So as I was introduced, I am Colette Brotman Ebsen. I'm the lead APP for surgical oncology. I've been at University of Chicago for over 5 years and working with our appendix cancer patients and families. So I'm looking forward to talking about not only the role of APPs in cancer care, but also surveillance as well as your survivorship. I have no disclosures. So today we'll chat about APP training in general, and then how we contribute to oncology and survivorship programs here. You will see us in every step of your care, from diagnosis to surgery to your post-operative care, and then for years to come, and how we work within the multidisciplinary team that will be taking care of you during your diagnosis. Just for those that don't know, so when I'm using terms APP or PA, they're fairly interchangeable. APP is Advanced Practice Provider. Within that group is nurse practitioners, physician assistants, certified nurse anesthetists. But in our surgical oncology group here at University of Chicago, we have 3 PAs that you may interact with during your time. We are licensed healthcare professionals, and we work in partnership and collaboration with our physicians. So we each have a supervising physician that oversees our licensure, our decision making, and so every decision is a collaborative decision used and made with the support of our attending physicians. You will interact with APPs in every step of your medical journeys, whether it's in primary care or surgery or other medical subspecialties. So I wanted to talk about the cancer continuum of care. So there's all these different steps in your cancer diagnosis that you'll see APPs involved in, but also what to expect on your end during these steps. Most often in our clinics, we are seeing patients present already with a diagnosis. So in this specific case study, we have a young woman who was diagnosed with an appendix cancer following a routine laparoscopic appendectomy. And her general surgeon received the pathology results and referred her to this tertiary site, as appendix cancer is very rare, and they often want more specialists to discuss these types of diagnoses. We often don't have a lot of information other than an operative report and a pathology report when we see you. And so I'm going to chat a little bit about kind of what to expect before your appointments and some things that may be set up beforehand. This patient herself, though, is otherwise fairly healthy. Other than her appendectomy or the removal of her appendix, she had a C-section in the past. And on exam, she looks good. Her incisions are healing well, and she's feeling up to her old self. Before your appointment, or maybe even at your first appointment, you'll meet with an APP as well as your surgeon, Dr. Moeller, for example. And we will gather your history. We'll hear about your general health history, your family history, and then we may ask you to get some tests, whether that's before your appointment or directly after your appointment. Those types of tests include blood work, like the tumor markers that Dr. Wong talked about. A CT scan, depending on what that pathology shows. Sometimes they're CT scans, occasionally we get MRIs. But we want to take a look at your chest and your belly and your pelvis. And then we like to review the pathology here at University of Chicago as well. And this is pretty common for other tertiary sites, that we like to request the pathology and review it here, which can take some time. So sometimes that's still cooking when we see you for your appointment. And then we like every patient to have a colonoscopy within 1 year. So sometimes it can take a bit to get in. So we'll order these before we even see you so we can start working to get you scoped in preparation for any treatments that are coming up. After meeting us, you'll get a whole bunch of referrals as well to meet all the other members of your multidisciplinary team. So if you have one of the types of appendix cancers that we recommend chemotherapy for, you'll meet with our medical oncology teams. We try to coordinate these on same day visits, or at least within a couple days of one another. For our younger patients and older patients, female patients, often we'll connect you with our OBGYN counterparts to talk about fertility preservations as well as expectations. If you are likely to have a hysterectomy and go into early menopause, we'll connect you into our menopause clinics so that you can be prepared for that transition. Most of our patients are also connected with palliative care. And palliative care sounds really scary, and I think people often equate this to hospice. But our palliative care docs are specialized in symptom management. And so while, of course, we'll help you manage things that come up along the way, we work in part with these palliative care providers to help with things like appetite stimulation, some mood issues, and other things that can come up upon your journey, whether that's pre-op or post-operatively. You'll also meet with our oncology dietitian teams for nutrition management, which is something that continues before surgery and then all the way through your journey with your cancer. And then we can connect you with our supportive oncology teams, which, as I mentioned, includes the palliative care and nutritionists, but also things like acupuncture and mental health services. Many of our patients will get tied in with physical therapists so that you can be at your strongest and most active before surgery and after surgery. And then also, as Dr. Wong mentioned, we also have our patients see genetic counselors to get genetic testing if that is recommended. So there's a lot that happens within your diagnosis. Not only are you getting the diagnosis, you're going to be meeting a lot of people and getting a lot of blood work and tests so that we can make sure we know the most about you to support you through your cancer care. If you are a patient who is recommended for chemotherapy, then you may interact with our medical oncology APPs in addition to our medical oncology providers to get prepared for chemotherapy, learn about your chemotherapy options, side effects, do testing for that, manage toxicities that come up, and then any dose changes and treatment modifications. Specifically at University of Chicago, you have your quarterbacking medical oncologist who's managing your chemotherapy, but during your treatment, you're actually seeing a advanced practice provider along each week and before each treatment session to check in on side effects and to actually order your chemotherapy for the week. Again, anything that is done by your APP is also going through your attending or your main providing oncologist. You'll see me again after your first visit in our surgical phase for yourself. So you'll see us in your preoperative visits where we're going through consent and talking about expectations like Dr. Moeller just covered. We will talk about what to expect not only for the patient, but also for the families. What do you expect at home once your family member comes home after surgery? What types of things will you need to support them and help them along this journey? And what do you expect in terms of, overall recovery over the next several months and even years? We are also here to talk about any resources that you may need and connect you with social workers or things that can support you if you need extra help at home or in the post-operative recovery phase. You'll also interact with us on the inpatient side. So after surgery, you'll see us. We'll help to ensure that you have a smooth recovery within the hospital. And then you will see us 1 week after you're discharged from the hospital, whether that's a virtual visit, a phone call, or in person. We want you to have an early contact with your APP to make sure that you're doing well, you're healing properly, and any issues we're catching early. Then you'll see your surgeon once the pathology is back, and we kind of do a big visit, usually with all of us, to check in. And then any subsequent visits, any symptoms that come up, it's either handled by the APP or the attending. You'll see your surgeon, like Dr. Moeller, for about 6 months to a year after surgery. And as long as things are looking great and your imaging is clear, then we'll transition you to our APP surveillance clinics. And that's where you'll get to really know me because you'll be seeing me every 6 months or every year or even more frequent than that. During this time period, we're ordering your imaging, we're ordering tumor markers and checking in on any symptoms that may come up. This can be a stressful time for our patients because scanxiety is a very, very real thing. Every time you get imaging, you'll be refreshing your My chart every couple minutes to see if those results have come in. And sometimes the results themselves can be really confusing. And so our job is to make sure that as soon as those results come in, we're on top of them, calling you and giving you an update and hopefully a clean bill of health on the scan, but also talking through any changes that may have come up. What's great about how our multidisciplinary group works is that we have something called our GI tumor board, where we review all of your imaging and anything that's different or changed, we're able to collaborate with surgeons, your oncologists, our radiologists, and all of these different folks that can look at the imaging and provide meaningful feedback on what we think is happening and what proper next steps are. So even though you may just be seeing me in clinic, you're often getting the minds of some of the most intelligent people here at University of Chicago as well on what they think that imaging is. We also build our survivorship around you. And so in addition to the surveillance, we want to make sure that you feel supported in all different areas of your life. In some ways, you'll notice that your APPs start to fill in as somewhat of a primary care provider for you for some of these changes that surgery or chemotherapy have brought upon your body, whether that's changes in sexual health, changes in your physical activity, your diet, things like that. So at every visit, you'll notice that we're covering things like when was your last colonoscopy, your mammograms, and asking questions about how you're feeling so that we can make sure that we're managing those issues as well and getting you tied to the proper resources so that you can take on this next chapter of your life feeling the best that you can feel. If we do have conversations about end of life, your advanced practice providers are also there for this, whether it's to assist in scheduling procedures that can palliate or make you feel better, connecting you with our palliative care docs, or if it does come to the conversations of hospice, then helping that transition go smoothly for both you and your family. But overall, your APPs work as part of your multidisciplinary group. You will hopefully get to know us for a long time, and we're here to support you, whether it's phone calls, answering questions, jumping on quick visits, but supporting you along this journey. Thank you.
Thank you. Thank you so, so much to Colette, Dr. Moeller, Dr. Wong. So we've got some good questions that came in. Some, again, were sent directly to me. Some were just right in the chat. So I'm going to just start. First question is asking about support and quality of life. How would appendix cancer affect fertility for someone who's looking to have children?
That is an excellent question. And it's a two-part question. So the first part is how we manage symptoms. We have a model in our institution that I believe is very strong and very unique in the sense that we incorporate palliative care from the get-go, very early on, because this is a journey. Then this journey is going to require different steps on treatment and navigation of goals of care. So we get the patient to see one of our palliative care specialists, even if they are going through surgery or they're going to go to chemotherapy, to start navigating those other things that come along with the treatment plan, which are sometimes medication side effect, lack of energy, or the stress, the toll that the patient experienced due to the cancer diagnosis. And that palliative care physician that work with us will be helping us to coordinate the next steps when it comes to symptom control. And if the disease, some patients come early on that we can cure them, some other patients we can prolong their life, but some patients may be too advanced, so they also will require palliative care. So palliative care is all along the journey, from beginning to end. In regard to the fertility, we refer the patients, as Colette mentioned in one of her slides, to the fertility doctors, because there are some patients that we know that they're going to undergo surgical menopause, or they're going to be on chemotherapy and they're young, so they get counseling and they get seen by the specialist. No all patients are candidate for fertility preservation, because if the tumor already has invaded the ovaries, they may not be qualified for that type of fertility preservation, or if there is mucin encased in the ovaries. But for other patients where they are younger and the ovaries are still spare, that is a possibility, and that is given to the patients. That referral is given. Also, we are beginning to incorporate what is sex after cancer, basically getting patients referred to the specialist so they can go back to a normal life as a partner, or whatever is that they feel that they need help with, because a lot of these treatments can affect their sexuality.
Great question. Okay. Someone asked, how can I best manage pain, stress, side effects during treatment?
That is kind of tied to the previous question, and I will let Colette take over on that, because she will help us a lot with us, helping us with this referral. But this will be part of the palliative care component, which is pain and a lot of the symptoms that can come with it. Do you want
Yeah.
some? Mhm.
There's, different symptoms that will arise at different steps in your cancer journey. And so, part of what our job is to educate on things that are normal along this journey versus what are things that are reasons to call us or even go to the emergency room. We work together very closely with your chemo doctors, with your palliative care doctors, and with our nutritionists to try to predict things that may be coming up for you, whether that's just not feeling well because you're not eating very well, or pain issues, things like that. And then we all will work together to manage that, whether it's with pain medications, with physical therapy, with more visits with our nutritionist, but trying to stay on top of things. And we really, really urge patients to be communicative to us. If something has changed in how you're feeling, let us know. We're never going to be bothered by a message or a phone call. We'd rather know and get on top of things rather than wait until things have progressed towards a little bit more difficult to manage.
And another thing I encourage the patient is we give referrals to psych-oncology, and I truly encourage them, because sometimes it's easier to talk to somebody that is not your family member about your fears, because a lot of patients want to stay strong for the family, or there are different family dynamics. So I'll encourage them to be able to talk to the psych-oncologist so they can learn strategies to cope with the disease, how to manage the emotions that come with being treated as a cancer patient. And we facilitate those referrals for you.
There's a question here that came to me directly. It says, does the body overproduce mucus in other areas when someone has a mucinous tumor?
No. This is because the tumor itself, the type of tumors come from the glandular epithelium. Remember what Dr. Wong was explaining initially, that the tumors are generated from the inner part of the organ. And these cells naturally will produce this mucosity. So you're not going to produce it in other parts. What can happen is that sometimes this mucus overgrow your own body. It may start fistulizing, which means start invading through the muscle and into the skin, or from the abdomen into the chest when it's very, very advanced. But it doesn't mean that you're going to be producing in your lungs or in your nose or anything like that. But if fistulized through the vagina or through the rectum, you may still having mucin coming out from those other orifices.
Okay. There's a question here. What signs or symptoms should I watch for after treatment?
As we mentioned earlier, there will be some symptoms that will be expected to have, like the ones that I mentioned, the diarrhea, sometimes constipation, the nausea, the weakness, the tiredness. That's all that is expected to have. That is something that will happen and eventually will get better as time goes by. The question is what the difference will be between a normal recovery or when the disease is coming back quickly. And sometimes it's very hard to say the difference because some of these symptoms may overlap. But if somebody that is doing very well initially and is recovering and goes back to normal life, and then a year later start having episode of bowel obstructions, and even if they resolve, we start worrying that this could be either the tumor coming back or scar tissue that is building up that is kind of kinking or obstructing the bowel, causing that blockage. And it's hard sometimes to tell just by a CAT scan because when this mucin of this carcinomatosis is coming back, the CAT scan won't be able to see it when it's early on. And sometimes we need to do laparoscopies to take a look inside, which means put the camera to take a look what's going on, or to rely on some of the tumor markers that the patient has been having along to see if it's something that is a recurrence.
Right. There are a lot of questions here, and just in the interest of time, I'm going to skip around a little bit because some of these weren't answered within the slides. There's a question about asking, are there any clinical trials for new appendix cancer treatments?
That's a fantastic question. We have clinical trials at the institution at the moment, no specific for appendiceal cancer. We have it for peritoneal carcinomatosis of gastric origin, and we have it for mesothelioma, which is another disease we treat with this cytoreduction and HIPEC. However, we have the PPAC, which is not a clinical trial, it's a treatment protocol that is not available in other institutions. And this is being treated for patients that are not surgical resectable, and some of them are converting to become surgical candidates because the goal of that palliative treatment is to slow down disease and to control some of the symptoms. But some patients, a small percentage of patients, about 10-15%, actually reverse the disease. And those patients we can take to surgery. There are some studies that are done at the present time looking at the translational components, trying to find targeted therapies on biomarkers. They are still not being used widely because they are in experimentation phase in the lab. We have a trial that is for tumors that, but it's not just appendiceal exclusive, it's also for other type of tumors in the abdomen that we work with the medical oncologist. So the way that we work is that if we find that you are no surgical candidate, the medical oncologist that is leading your care, we look onto those other clinical trials that we have that is not necessarily surgical trial, but medical trials that we would use for this disease. And in that territory, we have many trials that may qualify you if your tumor is coming from the colon or from the appendix.
Thank you all so much. There are some other questions here. I apologize. A lot of them were answered in the slide deck, and so I can't get to all of them. But thank you all so much, Dr. Moeller, Dr. Wong, Colette. Thank you all so much for being here today, for sharing your time and expertise with us. We really appreciate it. And thank you again for everything you shared with us today.
Thank you for inviting us.
Yeah, thank you for inviting us.
Sure, of
Have a good day,
Thanks.
everyone.
Yeah, and so you three feel free to jump off. We're gonna wrap up with everyone else here. So thank you again.
Okay.
Okay, so awesome questions, awesome information here. Thank you all so much for being here today. We